Good afternoon. Welcome to Clinical Case Series. My name is Dr. Olutayo Sogunro, and this is General Surgery Case number 2. We will begin by a history of present illness, a case presentation, and then move into a clinical discussion. This is a 23-year-old female who presented with a one-day history of epigastric pain radiating to her right side. The pain was sharp and waxes and wanes, and she's had one episode of emesis. She has nausea, vomiting, and epigastric pain. Her past medical history includes an anal fissure, and surgically, she's had a fissurectomy. Her family history is unremarkable. She denies any tobacco or illicit drug use. She is married. No medication she takes regularly, and she has no known allergies. So, what other history might you want to ask? This is a female, so we want to know about her gynecological history. She's gravida 1, para 1, and had her period 2 weeks ago. What would you like to do next? How about we do a physical exam? Her vital signs are grossly normal, and her physical exam, for the most part, is normal, with the exception of her abdominal pain, which was right sided, and it was tender to the epigastrium with no signs of peritonitis. Her labs were also grossly normal in terms of her CBC and her BMP. What other lab work do you want to order? Liver function test, or CMP. The main difference between CMP and LFTs are the bilirubin. The LFTs will give you not just the total bilirubin, but the fraction of conjugated or direct bilirubin, which will be very helpful in determining the etiology of hepatobiliary disease. In this particular case, while the patient was in the ED, only a CMP was ordered. All of her liver enzymes and proteins were within normal limits. Every lab varies slightly on the exact number cutoffs for these values, but generally, a total bilirubin greater than 1.5 is abnormal. Now, what would you like to do? An abdominal ultrasound. Take a look. And how about now? See anything? Notice anything? What is your differential diagnosis now? Based on her clinical information, this patient has symptomatic cholelithiasis. This is our preoperative diagnosis. The patient was taken to the operating room and a laparoscopic cholecystectomy was performed, and she was actually found to have acute cholecystitis on top of her cholelithiasis. Postoperatively, she did very well. She was started on a low fat diet. She ambulated, pain was controlled, and she was discharged that afternoon. Now let's have a clinical discussion about cholecystitis. Cholecystitis is inflammation of the gallbladder, most commonly caused by gallstones. It develops in 6 to 11% of patients with symptomatic gallstones. Women are more affected than men. In the United States, 14.2 million women and 6.3 million men have had a cholecystectomy. Prevalence rates vary by ethnicity, with the highest rates in Mexican American men at 8.9% and Mexican American women at 26.7%. Western Caucasian patients, Hispanic patients, and Native American patients as a whole have a higher prevalence. Pathophysiology. Cholecystitis can be calculous, which means with stones, or acalculous, or without stones. We'll talk about calculous cholecystitis here. It often occurs in the setting of cystic duct obstruction by a stone, which causes increased luminal pressure and inflammatory mediators, which can lead to ischemia of the gallbladder wall and pericholecystic changes, and can ultimately lead to necrosis, and in some cases, perforation. Some risk factors for developing stones include being a female, having a family history, pregnancy, diabetes, dyslipidemia, obesity, rapid weight loss, ceftriaxone use, and prolonged TPN use. Gallstones are rare to develop in children. Pregnancy is a risk factor for the development of cholesterol stones because it is associated with both a qualitative change in bile composition and delayed gallbladder emptying, both of which promote stone formation. Rapid weight loss is also a risk factor for stone formation. The exact mechanism is not completely understood, but it is seen in patients with low calorie diets as well as patients who've had gastric bypass surgery. Signs and symptoms of cholecystitis include right upper quadrant or epigastric pain that may radiate to the shoulder or the back. nausea, vomiting, anorexia, a positive Murphy sign, which is cessation of inspiration upon deep palpation of the right upper quadrant with pain. Workup and diagnosis includes laboratory work and imaging. Lab work, like we discussed, you want to make sure you look at your liver enzymes. And imaging can be an ultrasound, CT scan, HIDA scan, or MRCP. We usually start with an ultrasound. An ultrasound is both sensitive and specific for evaluating gallbladder disease. It should be the first imaging modality to use, and the only one really needed to make the diagnosis. It is minimally invasive without the radiation risk. The findings on ultrasound that indicate cholecystitis are gallbladder wall thickening greater than 4 millimeters, pericholecystic fluid, wall edema, sometimes called the double wall sign, gallstones, which will be seen as shadows. The common bile ducts can also be seen in ultrasound. A size greater than or equal to 8 millimeters or zero point 0.8 centimeters is generally considered abnormal. It can be concerning for obstruction of the common bile duct and usually warrants further investigation. The common bile duct generally increases 1 millimeter with every decade of life. So, someone who is 80 years old or greater may have a larger common bile duct that is not pathologic. A couple other things that can enlarge the common bile duct are previous cholecystectomy, as well as recent instrumentation, such as an ERCP. CT scan imaging is usually performed in the emergency department and can be an initial study when a patient has vague symptoms of abdominal pain and the ED physician or provider is evaluating for multiple possible sources. Gallbladder wall thickening, pericholecystic fluid, and gallstones can all be seen. A HIDA scan, also known as a hepatobiliary immunodiacetic acid scan, can be used to evaluate the function of hepatocytes. It can evaluate for acute or chronic cholecystitis, biliary leak, or biliary dyskinesia when an ejection fraction is measured and found to be less than 40%. It works by the injection of a radioactive tracer and imaging to see the retrograde filling of the hepatobiliary tree. A positive scan is when there is non-filling of the gallbladder after 1 hour. A HIDA scan is usually obtained if the ultrasound or CT scan of the abdomen pelvis was inconclusive for acute cholecystitis. An MRCP is an MRI that is sensitive to the hepatobiliary tree and can evaluate for multiple etiologies, particularly if there are any common bile duct obstructions or stones. It's usually not the first test. Here is a patient's ultrasound. You can see some shadowing or stones in the transverse plane view. Here, you can see the common bile duct. It's measured, actually normal, at 2 millimeters. Treatment. Medical treatment options are usually temporary and will not treat the underlying disease because the gallbladder is a source of stones and must be treated by removal. If a patient is too ill to undergo surgery but has acute cholecystitis that needs to be immediately treated, a percutaneous cholecystostomy tube can be used, which is often placed by interventional radiology. It can be used to have controlled drainage of the gallbladder in the acute setting with planned for cholecystectomy in the future. Ultimately, it usually stays in for about 6 to 8 weeks before operative intervention. If there is choledocholithiasis or concerns of it, an ERCP can be performed. An ERCP is an endoscopic retrograde cholangiopancreatography, which is usually performed by a gastroenterologist. Ideally, it's performed prior to cholecystectomy, and it's done to clear the common bile duct of stones and debris, and sometimes create a sphincterotomy to help promote drainage of the common bile duct. A laparoscopic cholecystectomy is the gold standard for treatment. It can also be robotically done, which is also very well accepted, and they're both minimally invasive approaches. If there are any concerns of aberrant biliary anatomy or concern for common bile duct stones while the patient is in the operating room, a surgeon can perform an intraoperative cholangiogram. During an intraoperative cholangiogram, contrast is injected directly into the biliary tree to help determine the anatomy intraoperatively using x rays. Routine cholangiograms are usually not performed and have not been found to prevent injury during cholecystectomy. However, they can recognize injury to the biliary tree and aberrant anatomy. Here is a representative video of a cholecystectomy. It's not the one performed in this patient, but a good representation. The gallbladder fundus is retracted superior and laterally, and an energy device, in this case a hook electrocautery, is being used to dissect out the hepatocystic triangle. Then the peritoneal attachments of the gallbladder to the liver are being taken down. Then the attachments are taken down along the medial edge. The important structures of the cystic duct, cystic artery, are being dissected out. The common bile duct is not a structure that is taken during a cholecystectomy. The critical view of safety identifies two structures directly entering the gallbladder, with the window of liver seen behind it. That portion was edited out of this video by the original creators. After carefully identifying the cystic duct and cystic artery and ensuring the common bile duct was not part of the dissection, then you can proceed to clip and transect the cystic duct and cystic artery, as seen. For the remainder of the procedure, you take the gallbladder off of the liver bed using an energy device. Then you remove the gallbladder from the abdominal cavity using a retrieval device, and you take it out of one of the larger port sites. The end. Thank you so much. I hope you learned about acute cholecystitis. If you have any questions, please do not hesitate to reach out to me. Thank you for watching.